Hi, this is Nick Fletcher, broadcasting from Children's Healthcare of Atlanta and Emory University, and this is Interview with the Pedipod. Today is a pretty special month. I have a really spectacular interviewee today. Dror Paley probably needs very little introduction, but if you're unfamiliar with him, Dror is a national and internationally recognized leader in limb deformity and limb deficiency. He is absolutely an innovator in our field. He's created over 100 operations. He's reclassified a number of diseases in, I think, a very useful and functional way. He's responsible for things like the multiplier, the super hip, the super ankle, amongst other operations. He's also authored and edited the Bible of limb deformity, something that I remember when I first read a little bit like the instruction manual for a VCR, but is incredibly complete and thorough in its assessment of limb deformity evaluation, and I think something that he really should be commended for. Dror is a Canadian by birth, but his story as to how he became a four-time fellowship-trained orthopedist who started really the limb deformity and limb deficiency evaluation for much of the U.S., how he has taken that to St. Mary's, where he is now in West Palm Beach, and created more of a destination medical care scenario is really spectacular. I think that probably many people within our organization have preconceived notions of Dror, and I'll have to admit that on some level I did as well, although I didn't know him much beforehand. And I will tell you, I had as enjoyable an hour and a half interview as I could have possibly asked for. He's incredibly engaging. He's thoughtful. I think he's very self-aware of his role in our society, and I could not thank him more for being such a great interview. So I hope that you all enjoy this as much as I did, because I really did, and I think he was great to have on. I, of course, hope that you all have great summers, certainly that are better than last year, and I thank all of you for your support of this concept, and, of course, Carter Clement and the whole podcast team for his assistance with this. So please enjoy this wide-ranging, really unique conversation with Dror Paley of St. Mary's and the Paley Clinic. Dror, thank you very much. I'm going to welcome you in today. For those on the call, Dror just got done with a long bike ride and he's hot, but it's he's going to enjoy a little bit of time sitting down with us, and I'm really appreciative of you taking the time to do this.
My pleasure.
So, it's interesting. I've now done over a dozen of these interviews, and one of the things that is been fascinating about sort of preparing for you is that most people don't have a ton of information online about them. If you look me up, most of my stuff is carried on the Children's Healthcare of Atlanta webpage, but you've got such sort of a storied background and such an interesting career. There's actually quite a bit of information out there. And so it was interesting getting a chance to sort of learn about you ahead of time. I know you are from Canada originally, but I don't have a ton of friends named Dror. And so I was sort of curious if you could talk about your family's background and where you grew up and sort of what you were like as a kid.
Sure. Well, I was born in Israel, and that's where I get the name Dror. Dror means freedom or liberty. I was born on Passover. My mother named me because Passover is the holiday of liberty, and so it's a Hebrew name. And then we immigrated actually initially to the U.S. In 1960 when I was 4, and then my dad was at MIT. So he came over for that. And then we were actually forced out of the U.S. because of vestiges of McCarthyism. My family probably came from a very liberal socialist background. My father actually, during the war, was displaced. He was a Holocaust survivor. He was in Poland and moved to the Soviet Union, and then he went to Palestine and immigrated to Palestine, which became Israel shortly thereafter. And my mother was actually born there. She loved to joke that she was a Palestinian. So when they applied for a green card in the U.S., they came up with this background that they felt was too socialist for the United States in 1963. And we were summarily shown to the border in 1963, and my dad had like a month or two to arrange to leave the country, and we moved to Canada. And he completed his PhD. He was doing PhD studies at MIT. He completed his PhD at McGill instead. And this was a serendipitous thing because, you know what? First of all, I think mentality-wise, this was more suitable to how we looked at life. And secondly, I think without, Canada has a very subsidized university education system. So I got to go to, one of the best universities, University of Toronto, and what was then rated and still is up there, top medical schools in North America. It was rated as in the top 4, was University of Toronto Med School. I got to go to that spending $1,076 on tuition a year. Now, you can't beat that rate, even back then. At that time, Georgetown was $20,000 a year. So gives you a perspective. And that really, I didn't understand, that at the time till I moved to the States in 1987. But it was really a fantastic thing. And I really value, I grew up with socialized medicine. I value I really benefited from the values I got growing up in Canada, with no prejudice, no black, white, none of this stuff that historically the United States inherited. And, a much more diverse culture. And it really prepared me for who I am, a much more cosmopolitan individual. I did an internship in Johns Hopkins in 1979-80. And then I went back and did the residency program in Toronto, which back then, and still probably to this day, but especially back then, was back and forth between Salter and Henry Mencken, who was the better program, Harvard or Toronto. And Salter used to joke around that, that Harvard thought that they were at the hub of orthopedics. And he said, yeah, because nothing moves very quickly at the hub. Everything moves quickly at the end of the spokes. And Toronto was at the end of the spokes where things moved quickly. And I always got a kick out of it. But Toronto is an amazing place to train. And in orthopedics in general, the people like Alan Gross, Marv Tile, Joe Schatzker, Bob Salter, Wally Babechko, John Costwick, just the list went on and on and on. Norris Carroll, Colin Mosley. These were my professors. They really shaped the way I learned to think. And I really credit that program for shaping thinking out of the box and really preparing me for what I was good at, which was really conceptual thinking. It gave me a tremendous foundation, a rock solid foundation. And because of that rock solid foundation, which serves me well to this day, I've been able to develop a lot of new ideas because I was so well grounded from my residency. So I'm forever indebted to my Toronto training. And I was lucky to be there before the exodus, before what was then called the brain drain of all these guys who were such big names in their own rights, and they all became chairmen of, orthopedic programs all over the United States. But I was there before that happened. Even Ed Simmons, before he moved to Buffalo, and Bob Gillespie before he moved to Buffalo, and all these guys. So that was really a pivotal thing. And I did fellowships. I did my first fellowship. I really did not like things like total joints, sports medicine, didn't like spine. And my favorite rotation in all of residency was the 6 months of vascular surgery I did as a senior resident. So I was a PGY3 when I got to do 6 months of vascular at my request. I requested.
Wow.
To do
probably the first and last.
Right. And it is why I am so comfortable around neurovascular bundles. to this day. And I do a huge amount of work around what I call my friends. My friends are the nerves, arteries, and veins. And I visit my friends. I don't overstay my welcome. And, I enjoy their company. And I'm always decompressing nerves and vessels and to avoid getting into trouble. But I'm very facile with them. And it's because of that 6-month rotation. And, I thought to myself, I'm in the wrong specialty because I really don't like this hard bone stuff. you know, and this like total joints. This is barbaric surgery. Like this is honestly cookie cutter surgery. It wasn't barbaric. It just wasn't interesting to me. Don't get me wrong. It's a revolutionary, amazing operation. I worked with Bob Jackson, who was, the pioneer of sports medicine and arthroscopy. And so I got amazing exposure in the days before what I call digital arthroscopy. You still look through the tube, and all that stuff. And David McIntosh, who invented the pivot shift sign. And these were my mentors. I got incredible training, but I wasn't interested in that stuff. The first rotation that piqued my interest was hand surgery. And I said, oh my God, I love soft tissues. And I love the fine dissection. And I love this, this anatomy. And I found spine surgery and total joint surgery gross. It was just too chunky, too big.
Yep,
it wasn't
too big.
It wasn't. People weren't gentle with soft tissues. I didn't like how they handled them. For a guy who chose to do vascular surgery intentionally, this didn't fit in. But as soon as I found hand surgery, I said, this is it. And so I signed up as a beginning of my PGY4 year, signed up for a hand fellowship. And then my next rotation was peds. And I said, oh, this is so much better than hand surgery. And it's a lot of soft tissues, and it's fine, and it's delicate. And I love these tissues and these kids. This is amazing. I'd never done kids before. And we only did kids once for 6 months at Hospital for Sick Kids, one of the greatest institutions for children. And I said, this is it. But I am always a man of my word. I'd given my word that I accepted the hand fellowship. I was already, I was one of several that had applied, and I got it. So I went ahead and did my hand fellowship when I finished my training. But
wow.
Meanwhile, I already arranged for a PEDS fellowship. So I did a year of hand surgery in Toronto with Bob McMurtry at Sunnybrook Hospital, which is also the regional trauma center, where Marv Tile, Joe Svatsker were.
Yeah.
And so everyone who was there became a trauma fellow and did a huge amount of trauma. Okay.
Yeah.
And we were also trauma team leaders. So we ran the trauma team. So I knew critical care. I knew all this stuff. And, and it was interesting. And I actually did like trauma, and I did my hand. So I finished kind of a trauma hand combined double fellowship. And then I, in the meanwhile, discovered the Lazarov. And I actually discovered that when I was a PGY3. And I spent it was very hard to get information on that. So I kind of researched that for a couple of years, and then decided to go over. I asked the guy I was doing my hand fellowship with to let me off for a month. And he did. And I went over to Lecco, Italy to check it out for a week in 1985. Okay. I finished my written Canadian exams, and the same night I got on a plane and flew to Italy.
No kidding. Wow.
And then I got there. So remember, I've now had two epiphanies, hand and children. And I got there and I said, oh no, forget about these two.
I found the real one now.
I'm going to be a limb reconstruction surgeon.
Now, Jeff, pardon my ignorance. Were there any similar institutes in the North America, or was Devastini and Illustrator basically
it was before anybody had paid any attention to this. Yeah. And in fact, I'll tell you a little anecdote. I mean, so I first heard about this stuff in 1983, and when I was PGY3, and a guy named Renato Bombelli, very famous hip surgeon, came over, and he was there for some conference. And he came to Grand Rounds, and at Grand Rounds, we were showing him cases. How do you treat this in Italy? And we showed him a bone defect of a tibia. And he looked at that, and he then explained with his heavy Italian accent how you cut the bone and then you slide it down gradually. It's a Russian technique and blah, blah, blah. And there wasn't one question. There was silence. And I thought, okay, I'm the only ignorant guy who's never heard of this famous guy, Elizarov. So I go to him in the coffee break and I said, I'm sorry, I'm just a junior resident, and could you please explain that to me again? So he drew it on a napkin for me, explained the whole thing. And this was the beginning of a great friendship between Bombelli and myself. And when he finished explaining to me, I realized no one in the audience knew what he was talking about, but they were too polite, okay, to say anything, and they didn't want to show their ignorance. Right. So I, after this, went and researched this. And in Canada, there was only, like, the equivalent of Library of Congress was in Ottawa. I was in Toronto, and I requested all these papers. They had English abstracts, and I read all this stuff. And then, and I didn't speak Russian at the time. I do now, but, I started researching this. And then Bombelli, at my request, sent me some literature from Italy. And it just went from there. And it was very painful to research this in the beginning. It was very slow, and then it crescendoed. I got more and more information. And finally I said, look, I'm not going to be able to get enough information unless I go over there. So I did go over there in 1985 for a week. And then my eyes just exploded. And I knew this is what I wanted to do. Finally, I knew it. And what I didn't realize is that it's an area that really encompasses all other subspecialties except maybe spine. So if you had a fellowship in foot and ankle, if you had a fellowship in hand, if you had a fellowship in total joints, if you had a fellowship in peds, it was all complementary. So this wasn't wasted time. This was all building blocks. So I came back from that and I said, okay. I called the peds. I'd already had a peds fellowship set up. I said, listen, guys, I'm already fully fellowship trained, and I don't want to do a full year. I want to do 6 months. And they allowed me to do 6 months. And I said, and I'm going to go to Europe for 6 months. And initially, I was going to do peds first, and then the other one next. But the next thing we discovered is my wife was pregnant, and that wouldn't have worked out. So we flipped it, and we went to Europe with her fully pregnant, and it was maybe the most wonderful 6 months with our 2.5-year-old child. My wife had a very easy pregnancy, and we had so much time together. It was absolutely like a 6-month honeymoon. Plus, I was learning virgin territory. I mean, I was learning from so many people. I spent time with Monticelli and Spinelli in Rome. I spent time with De Bastiani and his whole group in Verona. I spent time with Catagni and that whole group in Lecco. I spent time with Wagner. I spent time with Elizarov. I spent time with a whole bunch of other people. And I created this 6-month self-funded fellowship. And it was wonderful. And my wife didn't have to fly back till the end of November, and because she was 8 months pregnant at the time, and I stayed till December. Actually, arrived back December 21st. She gave birth on the 22nd, and
wow,
so it worked out perfect.
Yeah, kind of close, but yeah, you were there.
So
that's all that counts.
It was a fairy tale 6 months, and I learned 2 new languages that I didn't speak before.
I was going to say, so you didn't speak anything going into that.
I spoke French, I spoke English, and my mother tongue is Hebrew. So I already was multilingual, but I learned. I intentionally went there. I took all the books with me, and it's not like today where you can do it off of apps and so on. I took my little gem dictionary, and I took a bunch of other grammar books intentionally, planning to learn Russian and Italian. And
wow.
You know what? I couldn't do it today. I don't have a 30-year-old brain anymore. But my brain was like a sponge. And you know what? I've since realized that languages are something that my family is good at. My dad spoke 9 of them. One of my sons speaks 5. I speak 6. So I didn't have a hard time learning it. I was fairly conversant in Italian in 3 weeks. It took me about 6 weeks to speak Russian, so a little longer. I tell this to people, and people are incredulous, but it's true. And I was learning so much about orthopedics. I was learning about science fiction orthopedics.
Right.
By the way, when I told the people, so I went from Sunnybrook Hospital where I was doing the hand and trauma fellowship. So when I told at that time, one of my mentors, who's a dear friend and mentor, Marv Tile and Joe Schatzker, that I'm going to the Soviet Union. Remember, this is
the mid 80s.
This is Glasnost was just about to be mentioned, okay? And I told them I'm going to go there to learn this technique. And I remember Marv's comment. It says, Dror, what's a bright guy like you going to do going to the Soviet Union to learn some Russian technique that's probably voodoo? Okay. Why don't you go do something useful like learn total joints? I reminded Marv's, I think in his 90s now, and he's one of my favorite people. I've learned so much from him. And so I hope he won't be upset at me telling this story. But, it represented how we looked at life. Like you're too young to remember the polarized world of red and every other color. And we looked at life as them and us. I mean, that's the world that I grew up in. And, it was, so there was nothing valuable, nothing useful that could come from the Soviet Union. So it was a real uphill battle, which is probably one of the reasons nobody had actually learned any of this. We were so close-minded. I mean, another technique that came from there, same time, this is a contemporary of Lazarov's. So one of the biggest techniques in ophthalmology is LASIK. Okay. Radial keratotomy was the precursor of LASIK. It came from a Soviet ophthalmologist.
Oh, wow.
Okay. That all started there. Another voodoo technique, right? Anyway, look, the rest is history, everyone, but it was an uphill battle. Let me tell you
How did you get to Russia? I mean, I can imagine at the time it must have been a little bit hard for, North American. Obviously, you were Canadian, so maybe that helped.
Yep. Yep. So being a Canadian was huge. And I didn't, they didn't have relations with Israel at the time. So that wasn't a positive, but they never asked me about that, even though it says born in Israel on my I traveled on my Canadian. I didn't have an American passport then. I was coming from Canada, and so no, it was a very exciting time, very interesting time, and I was one of the few surgeons who actually got to know Lazarev personally because I could speak to him. And believe me, it was for Lazarev, I was some anomaly. Like the guy was born 1921, so he was 65 years old when I met him. Okay. Wow. And, in his system, I was 30. A 30-year-old surgeon is a nobody and can achieve nothing. And this is the first guy from North America that they sent over.
Right. Yeah, this is what you send us?
Exactly. So it wasn't until I brought him Viktor Frankl from joint disease and Stuart Green that he paid more attention, but I made that happen. Okay. And, the first Lazarev course we ran was in 87 at hospital for a joint disease. And November 87, and Lazarev came over. And, Victor and I organized that course. Victor made it very clear how it works. He says, Dror, let me explain to you how it works. He says, to run a course like this, it takes two guys, a young guy and an old fart. The young guy to do all the work, the old fart to take all the credit. I said, I got it.
So that's how it worked.
And Stuart said something else. So Stuart was involved, and Stuart says, Dror, let me explain to you how it works. Well, everybody was giving me a lot of free advice. I was 30 years old, and he says, and he points over at Victor. We were at this conference. He says, you see him? He says, he's a has-been. Victor is about 65 at the time. He points at me. He says, you see you're a will be. He says, you see me, I'm an am. So this was my introduction to how the world worked. But it was a very exciting time. And working with Richards Medical, which later became Smith & Nephew, and bringing all this stuff over. But, there were two kind of guys who got involved in this. And yes, I got involved. I was the earliest North American to get involved, but Europeans were already into this. It had come to Italy in 81. Okay, so this is 5 years later. Italians were well developed into this. It had come to France, Spain, Germany. These places already had the Lazarev method. Okay, so we kind of had a relatively late start, and actually Canada can claim to have started before the U.S. because I had to do my PEDS fellowship, and the head of PEDS, Wally Babechko, who I was doing my fellowship with, allowed me to bring the Lazarev device into hospital for sick kids. And then because I had so many fellowships and I already finished all my exams, they made me an attending even though I was a fellow. So I got to start my own practice and be a fellow. And my practice grew so fast. I did my first 52 Lazarev cases in Toronto before I moved to the States. And I already had a job at University of Maryland, but we were waiting for my green card, my labor certification, all that, because I was Canadian. And so November 15th, 1987, I started at the University of Maryland. And I remember asking them permission. John Kinzora was the chief. I said, John, this is my dream. I really want to do this stuff. And John says, that's fine. If you can find any of that stuff, you can do it. But I brought you here because we don't have a pediatric orthopedic surgeon. And I need you to develop pediatric orthopedics. I said, well, I also want to do hands. I have a hand fellowship. Well, we have a hand surgeon, but if you find any hands, you could do something. And, so I started there. That was November 15th. By January 1988, I had a 1-year waiting list. 1 year to get in my surgery schedule. My practice and patients were coming from all over the United States and around the world in a course of 2 months. It was insane. And I said, John, you told me I could do this, John Kinzora, if I got enough cases. I said, what if I get so busy? And so, eventually I brought John Herzenberg on and Kevin Tetzwer. So we grew the unit there. And of course, we did handle all the peds ortho as well as, and I was at a very early age, chief of pediatric orthopedics. What a joke, right? 31 years old, I'm chief of pediatric orthopedics in a non-existent program. But we grew it so big. Our practice was enormous. And it was a medical tourism practice from day one. And
why do you think that is? I mean, it's like this fairy tale.
Right? It is. Well, I know why it is. I did this conference in New York with Elizarov there in November 1st, 2nd, 3rd, 1987. I hadn't even started at University of Maryland. That was happening 2 weeks later, right? And when I arrived at University of Maryland on November 15th, the academic secretary comes to me and says, Dr. Paley, what do you want us to do with all this mail that's coming in? I said, what are you talking about? She says, well, we are getting x-rays being mailed to us, about 10 a day from everywhere, from Europe, from the United States, from Latin America. So this international conference that I ran created my career. There were doctors there from everywhere. And I was a chairman of the program. Not only that, but I was the only person there from North America who presented their own cases. Remember, I'd done 52 cases. And
right.
Ironically, so one of the things I did is, everyone knows me for deformity correction. I started explaining deformity correction. And I gave a lecture called Principles of Deformity Correction, believe it or not, in November 1987. I already was working these things out. I had no idea that was going to be one of my legacies, and how important it was. And in fact, it infuriated Elizarov. He didn't speak any English. So he would sit and listen to lectures and count how many times you said his name.
That's hilarious.
It was, he couldn't understand a word. And there was no simultaneous translation. He had a translator sitting next to him, but you really can't, so he'd sit there and he got really upset at me because this conference only about Elizarov, nothing else. And I gave this lecture on the principles of hinges and where hinges go and what effect it has on the osteotomy, angulation plus translation, this and that. I started explaining axis lines. Okay. I already worked all this out, believe it or not. It all came from trying to figure out where the hinges go. And I needed a more objective way that my brain could wrap it. Elizarov put the hinge in the same place every time. And it didn't, for a metaphyseal deformity, it went at the top of the bone or at the bottom of the bone, depending if it was proximal or distal. But that was about it. And it didn't make sense to me. And I started looking for the cora and center of rotation angulation. And, in retrospect, I had no idea how important what I was doing was going to become. No idea. It was just obvious to me, like totally obvious. And I didn't know that nobody knew anything about this. So I gave a simple lecture on this. And I showed cases where I'd implemented this. And people's eyes went. In other words,
Yeah.
so I got famous for what people called the Lazarov would show the magic, and I'd explain the magic trick. Okay?
Right.
And in fact, people started inviting the two of us together because they said, yeah, Lazarov stuff's amazing, but you cannot learn anything. You can't figure it out. So what they would do is invite Lazarov, and they would invite me, and they'd take him off shopping as soon as his lecture was over, and then they'd have me speak and explain the magic, explain the principles, explain how it's done. And that's actually, how that was especially internationally. Now, the guy in the United States who helped launch my career was Miron Tadjan, or Mike Tadjan.
Yep.
And Mike, of course, needs no introduction. He was one of the founders of the Pediatric Study Group. He created the Tadjan course. Now it's, the descendant of that is IPOS. He created IPOT, Orthopedic Think Tank, and so on. And Mike, I guess, saw something in me early on, and he latched onto me. And, I took the Tadjan course as a resident in 1985. I was faculty in 1988. Okay. I think that has to be some kind of record.
Yeah.
And not only was I faculty, but Mike said to me, I want you to design a 2-day limb lengthening course as a pre-course to the Tadjan course in San Francisco. And so I put together this pre-course on limb lengthening. And it was someone else basically giving me an open checkbook to invite everyone that I trained with. And so this allowed me to consolidate my relationship and my role with all of these big names. The only person he had coming regularly was Wagner. But, now I invited De Bastiani, I invited Aldegheri, I invited all the group from Lecco, I invited Spinelli, I invited, a lot of names, Julio de Pablos, and a lot of people came to this meeting. And basically, it was an open checkbook, as many as you want to invite. And again, I ran this, and this was, I'm now 32.
Yeah.
This is a big deal. It was such a big deal that it pissed a lot of people off. As you know, we have a very political society. And there were individuals that felt threatened by this 32-year-old guy who they felt had not earned his accolades. And they, without mentioning names, two of them in particular, very senior statesmen, who went to Mike Tadjan and said, Mike, if he comes back next year, we won't come back.
Wow. That's tough as a young faculty too.
Yeah. And, my good friend and mentor from Toronto was Norris Carroll. And I went to Norris and I said, and he also worked with Mike up in Chicago, Children's Memorial. I said to Norris, I said, what did I do wrong? I don't understand. Why do these people hate me? What have I done to them? I said, only one thing I can be accused of, and that is being overly enthusiastic and wanting to share everything I know with everyone, because I don't hide anything. I said, is that a crime? And Norris said to me something interesting. Says, Dror, in 12 to 24 months, it wasn't even 20, no, it was 12 months, that you've been involved. It wasn't even 12 months. This is like July 1988. I only went into practice in November. I'd already pissed everyone off by July. That has got to be
That's a record.
Another record.
Yeah.
And he says, you have achieved a profile greater than these people achieved in 20 years. He says, there's not a pediatric orthopedic surgeon out there who doesn't know who you are, and you're 32 years old. He says, yeah, these people are not going to let you continue on that kind of trajectory. They're going to stop you. You're going to have to earn your place. And I said, but I don't understand. I'm not asking, Miron invited me. He says, yes. And Miron disinvited me. So he had already invited me for 1989. And he calls me up and he gives me some lame excuse, which I saw through. And I said, Miron, what's going on? And he told me, he even gave me the names of the two individuals. Okay. And since then I became very friendly with those two individuals, by the way. Just, yep. But, they were not going to let me politically move forward, and I wasn't political at all. Anyway, bottom line is I asked Norris, what can I do? He says, do what you're doing. He says, keep your head low, keep doing research, keep publishing, because I was publishing at a frenetic rate. Keep publishing, keep teaching, and don't worry about it. He says, just keep doing the good work. He says, they're not going to, they're not going to be able to stop you, especially if you keep doing what you're doing. And he says, you know what? This will blow over, and Mike will invite you back a year or two later, which is exactly what happened. And I became a fixture at his course. In fact, when it came to creating the International Pediatric Orthopedic Think Tank, Mike, I don't think ever liked POSNA. He really liked the study group. And he hardly would attend POSNA. And so he wanted something more similar to the study group. So he had this idea, and he would bounce his ideas off of me. Like, who the hell am I? Even though I'm not coming to his course, he'd call me up all the time. He said, Dror, I want to know what you think about, he'd run and he had this idea for this elite group of pediatric orthopedists. They had to be over age 40. They had to be accomplished. They had to be invited. And the whole course was going to be case presentations. It was like the format of the study group. And 5-minute presentation and 15-minute discussion. And that's what the iPod meeting is. And this was, I think, 1995. And he says, I want you to organize the whole thing. So he would get me to organize things in the background and then wouldn't tell anybody my role. So, I think hardly anybody knows that I actually organized the original meeting in Chicago. And what the format, and then he wanted to create these bylaws. And I said, Miron, I'm not 40 yet.
Yeah, but you were the young guy doing all the work, right?
And it was 95, and my birth date is 56, so 96 I would have been 40. And he says, yeah, but I had just become full professor at University of Maryland, the youngest full professor at 39. And he says, Dror, by the time we get this organized, you'll be 40. He says, nobody's going to check your credentials in the first year. And, so I was the only young guy. Now there's a bunch of young guys invited to this organization. And I'm one of the old farts now. That's the irony. But, back then, I think the next youngest person was 15 years older than me and up. So, I'm very indebted to him. But meanwhile, back at back at the ranch, I was, because we talked about I was getting these patients from all over, I was getting amazing pathology. There was no one else. Everyone else was amputating limbs, right? And nobody was doing, big deformities, and especially congenitals. And I was getting more and more congenitals coming my way. And honestly, I didn't know a lot about them. I made a lot of mistakes in the early days. But in the beginning, it was very Ilizorovian type of approach. And then I realized it wasn't working for the joints. We had to do something better for the joints. So I remember I was tackling the knee joint, and what we would now refer to as the super knee procedure, I came up with it in 1994 with these extra-articular ligament reconstructions. I'm indebted to Dave McIntosh, who was my mentor, and I kind of modified some of his techniques. And, I was traveling a lot, so I got to learn from all kinds of people, So I brought in parts of the Langenschuld procedure for dislocation of the patella, and I brought in part of the Gramont procedure. It was a French guy that I'd met. And I kind of melded all of these and then created an additional type of extra-articular ligament reconstruction, the reverse of the McIntosh, going medial instead of lateral. And all this came together in 1994. And I did the first one of these. Now, I don't think I recognized the significance of it at the time. It wasn't until, again, later that you realize, wow, this was actually I remember the date in retrospect, but not at the time. And then 2 years later, I came up with the solution to solve the deformity of fibular hemimelia, which we refer to as the super ankle procedure. It's not one procedure. It's actually, again, my classification wasn't codified yet. It is now, it's published. But I was seeing so many that I could now categorize them into, this one has malorientation of the ankle joint, and this one has subtalar coalition malunion, and this one has a combination of both of those. And in this one, the subtalar coalition malunion is in valgus, and in that one, the subtalar coalition malunion is actually in varus. Okay, people are doing Ponseti for club foot because a fibular hemimelia looks in varus. Well, there's no subtalar joint. What are you doing? Okay.
Yeah.
And I recognized this really early on. And so I created a bunch of these modifications to the super ankle. But the first one, again, in retrospect, occurred in 96. And then the super hip procedure took till 97. Okay, the very first one. And believe me, these have all evolved. These were very primitive versions of these techniques. I try and teach young people the anatomy of an idea. You don't wake up one day and come up with a procedure like the super hip, which has about 50 different steps, and you figure out all 50 steps day one. It doesn't happen that way. You may figure out, part of that. And then you do it and you realize it's inadequate in this area or that area. For example, the original super hip recognized that there was an abduction contracture. So to treat the contracture, you had to lengthen the iliotibial band, but you also had to lengthen the abductor somehow. So I was doing a distal lengthening.
Not the slide.
The slide, right. And it was based on the Harding technique, which I'd learned in Toronto. Except instead of doing 1/3, I took the entire tendon and with the tendon of the quads and allowed it to slide. The problem is I changed the muscle tendon length ratio. And it worked intraoperatively, but all these kids, as they got heavier and taller, developed a Trendelenburg gait. Okay? And it took me a while. I didn't figure, nothing spoils good results like good follow-up, right?
Yep.
And, so I invented this in 97, but the kids weren't heavy enough. These were 2-year-old kids. They weren't heavy enough till 10 years later to overwhelm the strength of the abductors. And I started seeing this over and over and over. So in 2008, I think, which is, 11 years later, I did my first, what I call the abductor muscle slide, where I slid it from the proximal end, keeping the muscle tendon length ratio the same, and recognizing this was a unique muscle who had a growth plate. The muscle has a growth plate. How many muscles have a growth plate, right? It's one of the few muscles that's attached to the apophysis, and therefore it has a growth plate at its upper end. So you can take off the bone there, shorten the bone, and reattach the apophysis. Not only that, but the apophysis will then grow and retension the muscle.
Yeah.
But that didn't happen in the first super hip. Okay? Even though we were doing a Daigle osteotomy and we were splitting the apophysis, it didn't happen because I hadn't thought of it. Okay?
Yeah.
Hadn't thought of the importance of it. So a lot of these things evolved. Today, sure. And I've published it, that the super hip is a, very well codified procedure, very well worked out. There's really, I never say never, but it's as good a technique as it needs to be. Will there be some minor tweaks, and maybe someone else will come up with them? Sure, but it is there. But it wasn't there in 1997. It wasn't there in 2005. It just got there in the last 10 years. So these things, and why? So you might ask, why have I been able to do that? I've been very lucky. These are rare diseases. I see rare diseases in large numbers.
That's all you see.
Right. So when you see 200 CFDs a year, okay, and you do 30 to 40 super hips a year, you're going to get better at it.
Yeah.
And you're going to recognize some of the problems. And, I've been subject of a lot of criticism that I don't publish enough. I publish an average of 10 to 12 new articles a year. But I can't publish enough on, this year alone, it's May, I have 9 peer review articles either published or out there, and 3 or 4 book chapters. Okay, that's more than most people.
That's a big year already.
It is. And yet, if you look at a particular subject, I haven't published enough. And it's absolutely true. I have a very busy clinical practice, and so it's hard to keep up with, this. But it's been a tremendous evolution. So I've had the privilege, and I truly consider it a privilege, of getting to solve amazing puzzles and problems. And not just, a lot of people solve problems in one area. I've gotten to solve problems in a lot of areas because this limb reconstruction stuff, with the exception of spine, I have touched just about every area in lower and upper limb surgery, And, I do a lot of, most people don't know this, I do a ton of congenital hand surgery. I just came back. We have a center in Poland. We'll talk about the Paley Institute. I know you wanted to talk about that, but we have a Paley European Institute.
I did not know that.
And so we have a center in Poland. And for reasons I don't fully understand, I think it's just because there's not very much congenital hand surgery in Poland. I see a tremendous amount of congenital deficiencies of the hand. A lot of them have gone to Germany for surgery. And, it's one of the areas that I've done a lot of, especially radio club hand. And I developed a procedure called ulnarization. In fact, we just sent out a new paper on the 3rd generation of this procedure. Again, better. The first generation was born in 99. Okay. The newer generation solves a lot of the problems in the first generation. The second generation and first generation were both published. The third generation is going to come out now. And it has some elements that are more similar to centralization, but are still ownerization, and has one of the advantages that it doesn't kill the epiphysis. So no growth arrests. It has almost a 0% recurrence rate. It has good mobility. Those are three areas which centralization doesn't do well in. But this new one is a little more centralized than the older one. So it may actually be the one that gets everyone's attention because it's more appealing. Anyway, the point is, one of my visits to Poland, I did 11 ulnerizations in 1 week.
Wow.
All these kids have no thumbs. A lot of them don't. So what happens is if I do 11 ulnerizations in one visit, I do 11 policies.
You did policizations. That's an annuity right there.
Right. So
wow.
I was there last week and I did 6 policizations, 3 of which had been to Hamburg, had failed policizations because their digital arteries split too distally. No one wanted to take the risk. We succeeded. We got them split. No finger died. So I've done a lot in that area. No one even knows I do that stuff. But for me, it's been an amazing ride. I mean, because it's been so interesting. I've gotten to, I think, some people are better at doing one thing over and over and over again. I probably would have been terminally bored. And for me, it's the opposite. I'm a dinosaur that way probably, but I love doing, 100 different operations.
Last bastion of general surgery, right? That's what we do.
So, it's incredible in the morning to do a policization and then to follow that with, a big hip surgery, do a surgical dislocation of the hip and do a femoral head reduction osteotomy. So
yeah,
it is, I really do enjoy that. I need to let you ask some questions.
Yeah, no, this is great. I love it. But so I wanted to, I'm going to jump to innovation. I do want to hear, I have some thoughts on, or some of your thoughts on the Paley Institute, but, the innovation process is so fascinating. And as somebody in their 40s who's now 10 years into my practice, I realized at the beginning, I didn't want to mess anything up, right? Like it had to be sort of textbook. And I've learned through the years, I mean, it's just going to happen because not every outcome is not going to be great. You're going to learn as you go, that a lot of families with more challenging congenital complex conditions are very tolerant of sort of the learning curve of medicine that their kid is part of, right? And so I'm curious, as you went through, how the complications, which I know we all have, sort of affected that curve and that innovative process. Because the story that I'm hearing is very much that you're learning and you're adapting and you're changing and you're modifying everything as you go. But I'm assuming that most of that was done either because you didn't like an X-ray, because a kid didn't do as well as you wanted to, or an adult didn't do as well as you want to, or you just felt like you left something on the table. And I'm curious how that process has worked for you over time.
Sure. Well, let's take a good example is the super hip procedure. I started, you had all these hips that looked like a coxavera. We now understand that they're actually not coxavera. They're very complicated three-dimensional deformity. But so little was ossified that what was ossified looked like it was a very severe coxavera. And, I've always had an interest in hip surgery, and I've always understood, I'd read especially Bombelli's work and other people's work. So I really was facile with hip osteotomies. And so the problem was I knew that so I kept doing these hip osteotomies. And by the way, in the beginning, I figured out ways to use the external fixator to do that. I thought, here's a great minimally invasive way. And I could put this on, do a proximal femoral osteotomy at the upper end and a distal femoral osteotomy for lengthening. And I would do an acute correction. And then I'd get 100% recurrence of the proximal femoral deformity, 100%. And it was bothering me. I mean, I got the length. I didn't cause any harm. These kids had that deformity to begin with, but I wasn't making any progress on improving their hip deformity. So I came to the conclusion this closed technique is not the answer. The other part of it was I felt I'm missing something. I'm not understanding the pathoanatomy. So I've always gone back to pathoanatomy. And this was before we were doing MRIs on kids. Listen, we could have figured out nowadays, it would have been way easier. But in the 90s, honestly, I don't know if you find this incredulous, but you never did an MRI at that age. And we just didn't do a lot of MRIs on kids. You got to understand, the MRI only came out, I think, in the mid 80s or something.
Yeah.
And it took a while for it to percolate, and it was used for brain, for spine, for abdomen, and a lot more for adults than in kids. And then, so in the mid 90s, we were not putting a child to sleep to have an MRI. Very rarely. You have to have a really good reason. So I was figuring these things out based on x-rays and based on the literature. All my classifications, they actually turned out to be correct. But
they weren't based on, wow.
No, everyone probably thinks, I saw MRIs, I figured it out. No, they were based on that. And sometimes I'd open these things and I'd look at it and say, oh, that's what it is, And so, these things happened because I had a lot of them. And I didn't cause any harm to these patients, but like I said, some of them I didn't make better. But the patients had tremendous confidence in me. And I was moving the bar forward. They got lengthened. I always made sure their joints didn't dislocate. I've been doing pelvic osteotomies before limb lengthening for a long, long time. I actually published on that a while ago. Mm-hmm. So I was always doing that. And then it hit me. The problem wasn't the bone. The problem was the invisible part. It wasn't even going to show up on an MRI, by the way, that we had an abduction contracture, that your trochanter is so far posterior and so close to the pelvis that the abductors never grew away. The piriformis tendon running from the sacrum to the tip of the greater troch never grew. So the whole thing was tethered in external rotation. The psoas contracture kept the upper femur in flexion, so it could never extend. And when it was in flexion, it looks like varus. Okay,
right.
It wasn't really a real varus, and it took me a long time to figure it out, and took me even longer to be able to explain it to other people. I began to understand it, but I realized that until the day that you can explain it to someone else, and the real epiphany came when I started to write a book on this, and this book is still unfinished, but I had to explain this to the artist. And I had a really good idea of how it looked. And I used to get very frustrated with her. She couldn't understand what I was explaining. And of course, it's easy to get angry at someone else for your own failings at being able to explain it well. And, I remember later apologizing to her. I said, I'm frustrated by my failure to communicate. And then I figured out how to explain it. And actually working with the artist was one of the best thing ever happened. In fact, as soon as we get off this call, every Sunday I meet with her and we work more on some of these things, this compilation that will eventually show up in a book. But it helped me to explain this pathoanatomy. So this thing evolved over time. And what I realized, the epiphany moment in 1997, it actually occurred a year or two before, I just didn't have the guts to do it, was I understood that the primary problem was the flexion contracture, the abduction contracture, and the external rotation contracture. And that if you undid those, then the bony part, you could correct it. You could even correct a 90-degree deformity. And what came shortly after that, which is actually one of the most important discoveries that I've done. Well, I did this discovery years ago, but I didn't codify it and explain it, is the role of shortening. And look, you guys do this in the spine. Took you years to realize that if you do vertebrectomies and this and that, you can do huge acute corrections, right?
Yep.
Same thing in the limbs. When you have a 90-degree deformity, people got too hung up on preserving length, but the length's not there to begin with. You have to accept that the length is from the center of the femoral head to the knee. The fact that the femur first goes up and then goes down, forget it. That length's lost. Yep. It's gone. Don't get too caught up with it. So you can keep the distance between the hip and the knee the same and chop out the extra bone. And that was the key. And I figured all that out in 97. I figured, and it came together, and the first correction happened. And then I kept getting better and better. But then the more subtle things like the muscle strength took 11 more years. Okay. And so on. So innovation's not a one-step method. And innovation, you have to have the other thing that's really critical, your brain has to be well rested. Innovation occurs best, when you're not thinking about anything. Like, for example, the multiplier method, still one of the things I'm most proud of. I thought of that at 32,000 feet, sitting in economy class, flying over to Northern Ireland, okay, in, I think, like 1998. And I was just sitting there, my mind was blank and wandering, and I guess I was daydreaming and thinking about, and I said, I wonder what happens if you divide the length at maturity by the length at any age. And I didn't have the numbers in front of me, but I knew a few of the numbers, and I did them, and they calculated to the same number. So I literally landed, and I called Neil Bave, who was our physical therapist, but he worked a lot doing research with me. And I said, Neil, first of all, I woke him up because I was so excited, the time difference. I said, Neil, don't worry about the loss of sleep. This is going to be worth it. I said, I need you. He says, yes, I know it's Saturday, but I need you to immediately pull the Anderson and Green chart and do the following calculation and fax it. There was no email. Fax it to me, okay? Fax me the results. And I think it was like 4 a.m. And poor Neil. So he did all this. I had to change planes in Manchester to get to Northern Ireland, to Belfast. And by the time I landed, and I gave him my host in Belfast, by the time I landed, I had, this coming out of the fax machine. And I couldn't believe it. Every single division was almost the same number. And the multiplier method was born. It was born because I was at 32,000 feet, hypoxic, with nothing to do in economy class, sitting in a middle seat, crammed there, cannot sleep, and my mind just daydreamed. That's how innovation occurs. If people really think innovation, you sit down and I'm going to think of an idea today. You're absolutely wrong. And not everyone can innovate. It's a skill. There are things I'm not good at, but other people are. I am good at this innovation stuff. It happens naturally to me. In my residency, it got me in trouble because I would think out loud. I remember in my residency telling one of my attendings, why don't we just inject bone marrow into non-unions? He reported me. for this crazy idea because he thought I was trying to tell him to do human experimentation. Okay. I then went to the lab, and that study is published. It was one of the first studies on the use of bone marrow to treat bone defects in rabbits. And I wasn't suggesting to do it in a human subject, but I was like talking out loud. I just can't help it.
Yeah.
And so some people have this and some people don't. And you have to use, your God-given skills, whatever they are. In one of mine is this innovation. John Herzenberg, who was my dear friend and colleague till I left Baltimore after 22 years. I think we were partners for 19 of those years. I remember him saying to someone who said, that partner of yours, Dror, he paints outside the lines. And John said, no, he doesn't. He doesn't see the lines.
That's a good way to put it.
I thought about that and it was genius. It's true. Because a line means that there's a limit.
A border.
But more often than not, that limit is artificial. I was taught all kinds of dogmatic things. Even to this day, it says you can't lengthen more than 10 or 15%. When you go and research that, you realize that it's nonsense. It dates back to Kawamura and a bunch of other guys who created these rules. There's no basis for it. And in fact, the limit on lengthening is an amount and not a percent. I've proven that over and over. So what I do encourage other people, whether they're medical students, residents, fellows, or other attendings, is don't just accept dogma. Where did that dogma come from? I remember I was wondering, where did the proximal radius contributes 20% of the growth of the whole radius. So I went and researched it, and it goes way, way back to the 1920s, single case report. And ever since that case report, that number has been reported. It turns out that number's true.
But it was from a case report of the 20s, which I feel like is how orthopedics has been perpetuated over time.
Right, but we talk about it as if it's dogma. It's based on one anecdotal case, and they got lucky. Yeah. It is actually true. So we need to challenge dogma, and what I hope people take what I teach as a step forward, but not as the last step. And I challenge everyone to do better. I challenge I've pushed, this field's changed. Where we were with congenital femoral deficiency, fibular hemilia, tibial hemilia, radial club hand, congenital arthrosis of the tibia, where we were when I came into this profession and where we are now is a light year away. We've made huge strides.
Yeah.
And I'm very proud of that. And, I do understand that a prophet is never appreciated in their time. I'm good with that. I have no ego issues. People can continue to criticize me, to question me, no problem. I have no doubt that they will probably appreciate me more once I've retired, than currently. Because I've pissed a lot of people off. I've challenged everything that everybody has said. But not to be an asshole. I've challenged it because there are real good reasons to ask questions. And I'm sure people get annoyed, another Paley classification, another this. I'm sorry, what would you wanted me to name the Paley 1, 2, 3? How about just 1, 2, 3, 4? I don't really care. None of my classifications, for example, were named in order to see my name in lights. It is the standard within orthopedics that we name classifications by the author. Okay. I don't care whether they bear my name or not, but that is just playing by the rules. I'm sorry if I've developed a whole bunch of classifications, But they were necessary because, the Jones classification didn't predict prognosis or guide treatment. And there are so many unclassified cases with the Jones tibial hemimelia. The various CFD classifications were designed at a time when we amputated anything more severe than a small hypoplastic femur. Okay, the fibular hemimelia classifications similarly. I mean, talking about the amount of missing fibula, which has no bearing whatsoever on prognosis. Can we talk about the foot deformity, which is way more important? And then talking about number of rays, which also has no relationship to function. I mean, I can show you a video of one of my patients who has one toe, and he is one of the fastest kids on all his teams. And by the way, he has 3 toes on his other foot. Okay.
Wow.
And he's really fast, and he's really got amazing function. So so let's talk about things that guide treatment. Let's talk about things that are related to prognosis. So, I mean, these were the impetus to develop a lot of these things.
So I want to, because I want to make sure we get to your institute, which is another thing that bears your name. But I talked to you about this sort of on the lead-in, but for the guests that I've had on, your institute is pretty unique because pretty much everybody who I've had on has been at a major, hospital-based academic center. And I've always wondered, I have a couple of partners here in Atlanta who do a fair amount of limb deformity, and Jill Flanagan, who you probably know, has taught at the course a fair amount. And it seems like that was sort of a mecca for a while. I mean, you guys had a pretty good thing going, and I was enjoying hearing the story of you building that. I'm curious what the impetus was to come down to Florida. Was it to create something that was standalone that you had complete control over? Was there a need that you saw that wasn't being filled working through sort of a larger academic setting? I'm just sort of curious as to the process that allowed you to develop what you guys have now. And then I'd love to hear about how you've grown it, because a couple of my good friends, John Ashgar and Harry Shuffleberger, are your partners now in the spine world. And I think that's spectacular too.
Yeah. So, I mean, it is, by the way, today, so I guess it's the 30th of May. So yesterday was my 12-year anniversary for moving down here and opening the center. And the mayor of the county, it's actually had we'll talk about it, such a huge economic impact on Palm Beach County. The mayor of the county, to honor us, actually named May 29th as Dror Paley Day for Palm Beach County.
Wow. That's a pretty good gig.
One of the things I'm most proud of is I have my own day. It's pretty funny. But I've been down here 12 years. It's really incredible. I came here as a solo practitioner. We are 13 surgeons now. By September, we should be 14. The model here is very different. It's a medical tourism center. It is a private practice, but we are employed by Tenet, which is a large hospital corporation. But the practice is set up as a private practice, eat what you kill model. It has a lot of positives, and I'll talk about them in a minute, but you have to go back. So I started like all these other guys that you interviewed. I left Toronto. I couldn't get a job at Sick Kids Hospital because in the Canadian system, they have a certain number of jobs, and I only wanted to work there and nowhere else. And at the time I wanted a job, they were full. Little did I know that they were about to implode and everybody was about to leave. And a whole bunch of jobs. And in fact, when I was still on staff there and I had just received my labor certification, and 2 months later I was going to get my green card, John Wedge offered me a job to stay, which was very tempting. But I told you, one of my things is if I make a commitment, I will not go back on it. And University of Maryland had recruited me and had sponsored my green card, and I decided to go ahead and that I'd come back to Toronto if this wasn't going to work out. So I moved there, as I mentioned, and was there for 14 years. I played the whole academic game. And, but even within that, I grew our group. And I remember, I came on, this is for the young guys. I hope they hear this part. My starting salary was $74,000 a year. Okay, these guys are getting like $500,000 starting salary. This isn't that long ago. I mean, this is not 1920. This was 1987. It was $74,000. If you work out, it still doesn't follow the math, for what the dollar
was. It's still pretty low. Yeah.
And I generated between then and July 1st, I still remember, I generated $750,000. Okay. And so 10 times that. And I asked for a raise based on that. Could I get $100,000? And they actually gave me $115,000. For a university guy, I moved up quickly and I ended up getting relatively well compensated for that day and age. My highest salary after 14 years on staff, okay, is still lower than a starting salary for a post-fellowship guy, and I had 3 fellowships, okay? And, I was never motivated by money. I called it the corruption of medicine. I was never corrupted by it. I didn't care, the payer source, the payer mix, the this and that. Now, it so turned out because I had a really great payer mix and patients coming from everywhere, and a lot of them uninsured because they're coming from Europe, South America, Australia, everywhere. They were paying cash for their treatment. I didn't get $1 of that, didn't even have a bonus structure back then. I mean, in retrospect, it was legalized theft, But I worked for the university, and I did not leave because of what they were paying me. We did get recruited, and and I did look at a bunch of chairman jobs. I was offered my first chairman job in 1996. Okay, age of 40. It was offered my first chairman job. I became full professor at age 39. And but it wasn't about money. It was about, I loved the work I did. It was such an exciting time. And it was, it's still such an exciting time. I mean, it's hard to be in a field where it's exciting for 30 plus years, but really this is, this has been incredible. But we got recruited because Sinai Hospital came to us and made us an offer we couldn't refuse. They built us our own hospital. They built us a building called the Rubin Institute of Advanced Orthopedics. And it was just John Herzenberg, myself, and I recruited Michael Mont from Hopkins. And it was the 3 of us. And we brought on, I think, one of our fellows, which was Janet Conway. And so it was the 4 of us, actually. We used to have Kevin Tetsworth, but he moved to Australia. So Janet came in to replace Kevin. And we grew that thing. We became the busiest orthopedic group in the state. Made U.S. News and World Report and all that other stuff. And it was really an amazing place. I mean, we got paid better than at University of Maryland, but not that much better. And but it was really an amazing place. And I ran a $2 million budget. I was in charge of it, and I had 200 employees. I was in, it was a very big job. And, it seemed like our administration had great vision, but I started butting heads with them and had, when they started to say, how much bigger do you need to grow this? I knew it was over. And you know what? Divorce, empty nester, it was the right timing. I always loved Florida. I actually looked in Florida several times. I always wanted to live down here. And so I decided, I've got a practice will follow me to the moon. And it doesn't matter where I set up, they will follow me. And so why don't I choose a place I want to live rather than be a slave to being in a big medical city like Baltimore, like Boston, like Cleveland, like New York, LA, on and on and on. And it's a long story, but I ended up in West Palm Beach. Okay. And this is a little heaven on earth. I don't know if you've ever been down here.
Oh, yeah.
I live on the water.
I was at a lacrosse tournament not long down there. It's amazing.
It's amazing. And, it's a beautiful place to live. It was all, let me tell you, it was like serendipity, one thing after another. I found this place serendipitously. I met my soulmate, my second wife here, Jennifer, serendipitously. And it just, somebody wanted me to move down here. And you know what? All my patients, let's say 90% of them moved, but 10% of them stayed in Maryland. And the 10% was replaced by a huge volume from this large state called Florida and the entire South. And so my practice doubled in size by the move. And I, was a single practitioner. So I started bringing on, one partner at a time. Like I said, I initially brought on partners in my field, but then I realized that I built this infrastructure. Oh, by the way, Sinai Hospital, I was a hospital employee. So I went from university employee, hospital employee, and now I kind of moved to a private practice, but an employed private practice by a big healthcare corporation, a for-profit group. And only after a year or two here did I finally understand something. And this is a message for all of you academicians. I was institutionalized. You're all institutionalized. It's not meant to be an insult. I'm a diehard academic. I still do tons of research. But I think it's improved. A lot of academic institutions now are paying, market rates. A lot of them are paying fair market value. But still, most places, for example, don't allow you to buy into a surgery center. And in private practice, you can. Why shouldn't academic guys be able to buy into a surgery center, for example? Most places don't allow you to profit from your ancillaries because the university wants those ancillaries or the hospital wants those ancillaries. So what I've realized over time, and it's been a learning process, is that we all sign away our lives in what I call legalized theft. And for whatever reason, our insecurities or whatever, it's just, it's easy. We're academically committed. We're not corrupted by medicine and so on. We're not mercenary. We end up accepting what I think are really bad business arrangements. And while it was okay for me to do that, coming out and earn $74,000 and bring in $750,000 and not even think about it, you know what? I'm a little bit older and I understand it better. Look, I came from Canada and that influenced how I looked at things for a long time. I don't look at things that way anymore. I really think that it needs to be a fair arrangement. And I think, these days, if we want to keep people in academic medicine, we should allow them to be entrepreneurial. We should allow them to buy into, ambulatory surgery centers. We should allow them to own their own ancillaries and to profit from them. Yeah, the dean doesn't need to get as much money, because we are subsidizing all kinds of departments. We're giving money to the dean. I'm sure I'm going to piss lots more people off today, but I'm totally okay with that. We need to, I think that, look, I'm a diehard academic, but academia is at great risk if it cannot compete with some of the systems in place in private practice. Private practice is what I've learned, it's the gold standard. There's a lot of downsides to it, but it is the gold standard.
Yes.
I'm a full-fledged American now, okay? I still believe in socialized healthcare, but I'm a full-fledged entrepreneurial American. And I really believe that you can still be academic. Academia comes from within, not from without. You think because you go to a university, you're academic. There's so much deadwood in terms of academic deadwood in universities. Academia comes from within, okay? If you enjoy publishing, enjoy doing research, absolutely you should do it, okay? And it doesn't matter what kind of practice you're in. I'm not disincentivized. I do it because I love it. In fact, it's the opposite. I think I am actually I do have an academic appointment at FAU and at University of Vermont, and previously University of Toronto for a while. But I don't do it for that. I don't do it because I'm trying to climb the academic. Okay, I did that. You're right. I was assistant and then went associate and then went full professor. And at the time, it was really important to me. And I played the game. I've been president of LLRS. I actually started the organization. Okay. I've been head of the ILLRS and all this ego game and all this stuff. Great. Wonderful. And that's really important to a lot of people. At the end of the day, you're going to realize it's got to be more than just ego. But in retrospect, a lot of it was ego. And a lot of it is ego for a lot of people. But I really think that what we need to do is deinstitutionalize ourselves, choose the kind of practice we want, and practice whether it's within a university setting, within a hospital setting, within an employment model with a for-profit or not-for-profit group, or in pure private practice, and design your practice around that. That's my big belief. Now, that's what we built here. Now, we have a different model because it is a medical tourism model. I go after individuals whose patients will follow them. Okay? So, yeah, when I brought David Feldman here from New York, David was chief of pediatric orthopedics there. His practice followed him. Okay? Because David has an incredible reputation. It's all about reputation. And, and to some extent, it's monetizing your reputation. You built this whole thing up. A lot of these academic guys have never monetized their reputation. Now, David's still publishing, still doing research, still looking after patients. He's a superb surgeon, superb teacher, still involved in all of that. And he actually has far less headaches, and he has an ownership in an ASC, and he gets ancillaries, and he's in a eat what you kill model. Okay. Yep. And I brought, Tom Minus in the adult world. The number one cartilage repair guy, the guy who started it all, with Peterson technique, cartilage repair, all of that. He left the Brigham Hospital. These guys are coming. These are heavy hitters. They're coming from big named institutions. He's here. These guys have ended up with a very pleasant, efficient practice setup where they have great infrastructure, great access to operating rooms, far fewer headaches, less committee work. And Tom runs prospective databases for all his patients. Okay? He has his own full-time research person. He's making multiples of what he made at the Brigham. So is David. Okay? And at NYU. I brought Matt Dobbs down here, one of the more recent.
Yep, recently.
Okay. Matt was at WashU. Matt is a Nicholas Andre Award winner. He's a Kappa Delta Award winner.
Yep.
These are the Nobel Prizes of orthopedics. The guy has, NIH grants, runs a genetics lab still. He's as academic as they come. He has patients coming to him from all over the world. Okay. And he's still as academic as he was before. He has a way better practice setup without getting into much details. He owns an ASC. He gets ancillaries. He earns a lot more money. He sees actually more patients than he did before, has more access to OR time. Okay. So, and I can keep going. This goes on and on. And these guys that we've got here, Brad Lamb, who's a foot and ankle guy, Craig Robbins came from University of Mississippi, he's a peds guy, and so on. And we've now begun bringing the younger generation, Claire Shannon, who's a Pedipod, and, she's a superb surgeon. And, she works closely with me. Aaron Huser, another one. He was at Gillette. Claire was at Johns Hopkins. So we're not just bringing the older guys, we're bringing these younger guys to eventually take over the practice of the older guys. So there's a lot of succession planning built into it. It's very strategically built. And
I can tell.
You mentioned Harry Shuffleberger. Look, Harry's the, I guess I would call him now the grandfather of modern spinal instrumentation.
Yep.
I mean, I remember when Harry was introducing the Cottrell Dubussé in 85. Okay, that was my vintage. I remember that. I used to send Harry cases, from Baltimore to Miami. All right. We are honored. Harry's in his mid 70s. We're honored to have him here. I mean, it's really, and Harry, you need to ask him sometime what he thinks about his current practice situation compared to being at University of Miami for his entire career, and how the difference in freedom he has here. John Ashgar, who's a superb guy. Okay.
Yeah.
And John, and
well.
Again, I feel so honored to be associated with all these guys. These are awesome guys. Every one of them is an academic orthopedic surgeon, by the way. Every one of them is innovating, teaching courses, writing book chapters, writing books, creating new devices, publishing peer-reviewed papers, and on and on and on. And, it's a little bit, if you want to look at it, it's a little bit kind of like William Beaumont and Harry Herkowitz's group, where and look where that's gotten.
Right.
Jeff Fishkin runs that group. I mean, Ira Saltz, great. They were a private practice group. They were one of the first to kind of, break the mold. I mean, they now run a residency program, right?
Yep.
So we are a different model, and we're one of the first models where what I target is surgeons who are at the top of their game and who have huge reputations and who patients will follow. So like a Matt Dobbs, where honestly, Matt's practice has grown, not gotten smaller. He left WashU, and being on the East Coast, it's actually improved. It's easier to get here than to St. Louis.
Yeah.
And so he's got huge following from all over the world, and he hasn't missed a beat. Steve Quinnen, well-known trauma reconstruction guy from University of Miami, he's joined us, and so each of these guys brings a very unique skill set. And I haven't recruited local guys who happen to have big practices that might want to join us. It's not about the revenue of bringing in some big local, because I can tell you, we have a lot of people knocking at our door. Our model is specifically looking at doctors with high reputations, with referral basis, where patients will follow the doctor. I know a lot of big institutions think they own the patients.
Right.
They do till the patient leaves and goes somewhere.
Until they go elsewhere.
Right.
Yeah.
And if patients don't go somewhere else, they don't have such a big reputation.
Yeah. Well, listen, Dror, this has been so enjoyable, and you're somebody who I've had the opportunity to listen to at IPOS, and obviously our worlds don't cross too much between spine and limb lengthening and reconstruction, but this has been really enjoyable, and I'm glad we got a chance to do this. And I look forward. I know you've been a regular at IPOS, and so I look forward to seeing you there again. And so, thank you.
Yeah, no, IPOS. We talked about the early days with the Petagin course, and then Chad Price's Nemours course, and now IPOS. And I have to say, of all the courses that I attend and participate in, and I hope to participate for many years to come, it's actually been a real privilege to be part of that one. It is really one of the best, if not the best, of all the courses that I do participate in. And it's fun. I enjoy it. I'm sure one of these days they're going to retire me, but hopefully I've got a few years left with that.
Yeah, hopefully. Well, thank you so much. This has been a real joy.
Thank you.